Good afternoon, everyone, or as I learned to say in my first teaching job at A&M, howdy. I'm also a proud Houstonian, so I need to report to you all that I have travel papers from the mayor of Houston that require me to be back in our city by midnight or I'm subject to dire penalty, there being no rivalry between our two great cities. And of course, both of us live in the second best city in the state. We all know the first best city is Fort Worth. When you got the Kimball Art Museum, right, and the Fort Worth MoMA, I love the art museums in Houston, but sorry, they just don't match up. Okay, so I'm going to talk about ethics with you all, and so we're going to talk about responsibly managing emerging ethical challenges in newborn screening, and we're going to do two things. First, I'm going to give you a conceptual vocabulary in which to think about these ethical issues. Then we're going to work through some of the very issues that Dr. Powell set up for us, and we're going to think about them together. What you will discover as we go through that list is it gets harder and harder to think through these issues. And so the area of bioethics basically divides up into two groups. There's stuff we can figure out pretty easily. The challenge then becomes how do we get it done? And then there's stuff that's just really hard to figure out. And we'll see we're going to start with the stuff that may be straightforward and then get pretty quickly to the stuff that's hard. So we're going to give you a nomenclature, especially the concept of what's an ethical obligation. We'll define the components of an ethical framework, and then we'll put those together to answer the question, how should we respond to the increased scope of next generation sequencing in the context of newborn screening if we go that way? The principal barrier to it, I think, is twofold. One is cost, and the second of all is the delay in getting the information for conditions where you need to know very early in childhood what to do with it. But if the turnaround time can be sped up, I wouldn't be surprised, but I wouldn't also be surprised that the cost of that will go up as well, because there's opportunity cost. Those people are pulled off other things, and that cost has to be covered as well. So first, just to get cleared up on language, genetic testing and screening is language that can be a little fuzzy. So as a philosopher, the first thing I try to do is get language as precise as we can get it. So genetic testing seeks a diagnosis of a condition, disability, disease, disorder, or syndrome. You're after all of those in an individual patient. But genetic screening, as I hear it being used, is vague among three meanings. First, it seeks for risk assessment. That is, what is the increased or decreased risk of a particular person for a particular condition, disease, or whatever, against a general background population of some kind. Next, it seeks diagnoses of conditions in an entire population of patients, or it does both diagnosis and risk assessment in an entire population of patients. And failure to be clear about that is bound to create confusion. So I suggest that we think about that genetic screening we should think about as risk assessment. That is, we're trying to figure out what is the increase or decrease risk of disease in a particular patient, which means that we need to replace genetic screening with genetic risk assessment and then population-based genetic testing. So newborn screening, as I understand it, is population-based genetic testing. But next generation sequencing is going to add risk assessment to the capabilities. Is everybody with me? So it's already getting hard, and we're only on like slide 3. But I'm just doing my best to try to keep this as simple as I can. Then we need to do, this is just standard language from medicine, so primary prevention is you try to prevent disease from occurring in the first place. Secondary prevention is a patient who has been diagnosed with a disease or disorder. You're trying to prevent the onset of signs and symptoms. And then tertiary prevention is the disease process has begun, it's manifested, and you're trying to mitigate its effect and make it as least intense as possible. Then you want to think about this in a deliberative way. So the example of that graduate student who ran his own fetal son's sequence was what's known as an enthusiast. And this is someone who believes something without evidence to support it. This was condemned in the history of the philosophy of medicine 500 years ago by Francis Bacon. So 500 years later, we should catch up with the program. It shouldn't take that long, right? So we need to be deliberative. You have to stop and think. He did not stop and think. Did he, by the way, did he have his wife's permission to do it? Do we know? I'll bet he's in a world of trouble. Right? Right? You can call a man stupid, you can call a man a man. You don't have to say stupid man, why waste words? right? That's my wife speaking, by the way. So what's deliberative clinical judgment? That's what we need here. It's got to be evidence-based, as we saw in the previous talk. It's got to be rigorous. You've got to really think through everything you're supposed to think through. It should be transparent. You should be able to explain every aspect of your thinking, and those three together make you accountable to others. And this is the antidote to quick thinking, which is what we're wired for primarily. The behavioral psychologists, I think, have now produced overwhelming evidence that most of our thinking is with the quick parts of our brain. And we have to actually force ourselves to, or not force ourselves, but discipline ourselves to be reflective and slow down and do slow thinking. And deliberative clinical judgment is required in all clinical practice. Genomics and genetics is no exception at all. But it's also going to be required of patients and their surrogate decision maker, including parents of newborns. So a challenge is getting patients or parents to slow down, to become informed and to think before they make any decisions. And clinicians have to get in the habit of saying, we're not going to make the decision yet, we're going to sit and think. I underwent a major procedure by one of our physicians 4 years ago in my medical school. He made me think about it for a year in 3-month visits apart before it went forward. That's deliberative decision making. Not that it will all take a year, but you take time and you watch out for your impulses. By the way, my impulses are flawlessly correct. And so are yours. It's the folks who aren't in this room who have a problem in that department, right? Now, what is health? It's normal anatomy and physiology, and we have to remember our George Engel. It's biopsychosocial. We have to watch out for reductionism of human health to genomes. And there's a tendency of that that's very strong. And Engel introduced his concept 60 years ago precisely as an antidote to what was already the biomedical reductionism of his day, which I think was to cells, not to the level of molecules. And then we have to figure out what is an interest. So when does somebody have an interest in something? It's a stake one has in a future state of affairs. And then we have to distinguish our legitimate interest and our mere interest. Health interests are always going to be legitimate interests because a good state of health is an essential condition for every other thing that a human being undertakes in his or her life. And so it's a systemic interest that affects all of our other interests. And then what does it mean to speak about a patient? And it turns out it's very easy to become a patient. This concept was introduced into the history of medical ethics, by the way, at the end of the 18th century by two of the giants in the history of medical ethics, John Gregory, a Scottish physician philosopher, and Thomas Percival, an English physician philosopher, two absolutely remarkable physician ethicists. And their concept is very simple. An individual is presented to a healthcare professional, and there's something that person can do to help, if only to make a diagnosis. Right? Don't underestimate, especially for parents of sick kids who have been through that diagnostic odyssey, if you can give them an answer, even if you can't give them a treatment plan, it's really important to them. And we got to make sure that that doesn't get lost in this debate. But it's very easy to become a patient. So a newborn who is born in the presence of a healthcare professional becomes a patient, and that therefore brings all of the ethics of newborn screening under professional healthcare ethics. And that's the framework in which we have to think about it. And of course, power is being exercised, including power backed up by the sovereign state of Texas, right? Which we all respect, right? All of us respect the institutions of government, right? As proud Texans and Americans know, we're deeply skeptical about them, right? I've walked the battlefield at Yorktown in Virginia. I know what happened there. We threw off the yoke of English tyranny, right? So we are suspect about power in American culture. What is it? It has two components. It's the ability to make a decision, and then it's the ability to carry it out, either oneself or through others. So when that blood sample is obtained on the card and sent in, power is being exercised by the state of Texas to carry out its public health functions in our state. It's a legitimate form of power, but it's power nonetheless. Now, should we think about the relationship between parents and their children? The standard way we think about everything in the United States is I have my rights, who are you to interfere with them? Right? And especially if you're the representative of the state, who the blankety blank are you to interfere with them? That's a mistake in pediatrics. The fundamental relationship between parents and their children, especially children who are patients, is one of a duty to protect. So the language is that of parental responsibility, and that any rights a parent have are a function of whether they're responsibly carrying out decisions on behalf of their child. Now, that's not original to me. That's original to the American Academy of Pediatrics in its statement on parental authority way back in 1995. So it's a very durable statement. It's been in the pediatrics literature for a long time. And it's why the AAP says we do not ask parents for consent. We ask them for permission, because they are supposed to authorize what's in their child's interest. Unlike you and I, where we have to get consent, you and I are allowed to make health decisions that are reckless to our health. We would be very unwise to do that, and a conscientious clinician is going to tell us that in a respectful but persuasive way, I hope. But parents know. So they are duty-bound ethically to authorize what is in the interest, the health-related interest of their child. And their power should be exercised over their child under that constraint. Do you see how you start to put these concepts together? And your thinking starts to become progressively more precise if I'm doing my job correctly. So what's created then are ethical obligations. So what is an ethical obligation? It's behavior that can be shown by appeal either to ethical principles or to virtues to be required of us. So I agreed to come from Houston to Dallas to make this presentation. I had an obligation to do that. When my alarm went off in Houston at 4 o'clock in the morning, and even our dogs were not happy to be gotten up at that hour. I'm a morning person, so I didn't mind, right? My inclination to get back into bed violated my ethical obligation. I had to get up and then come to Dallas. That was the hard thing I've done so far today, right? When you all come down to Houston, you have the same experience, right? It's just going in the other direction. So obligations constrain our freedom, and that's precisely what they're designed to do. So in the area of, as genomics expands the capacity of newborn screening, will parents be under an ethical obligation to authorize that expansion? Should their freedom as parents be constrained by such an obligation? That becomes, now you can see why it's hard. This is going to be hard stuff to figure out. But ethical obligations are also prima facie. That means at first blush. What that means is if someone makes a case that you or I are obligated to do something, we're obligated to do it unless we can show there is a stronger obligation that should replace it. Unless you're of the school that is all obligations are absolute, that is without limits, there are almost no such obligations. Our moral lives are always constrained by other obligations, and we have to find ways to negotiate and balance among those. And we'll see that, plus your legitimate interests can set limits on your obligation. We are not obligated to sacrifice ourselves endlessly in our moral lives. There have got to be reasonable limits on that, and a great struggle in our lives sometimes is to figure out where those reasonable limits are. Now, what's a legal obligation? That's when you have an ethical obligation and the state uses its power to enforce it, either through the civil law, that is where you injure someone and that person seeks money damages against you, or the criminal law, and that is where you injure someone and also injure the community, and the community is going to use the sanction of fines or imprisonment or both to seek retribution for what you have done. Now, there's a very important relationship between ethical and legal obligations that we've got to keep clear because it gets confused all the time in our discussion. That an argument shows that parents in this circumstance, or healthcare professionals, have an ethical obligation to a pediatric patient doesn't establish that we should enforce it with the power of the state. Because the ethics of the use of state power require additional considerations. So the pediatric ethics is based on the obligation of clinicians and parents to protect the health-related interests of children who are patients. If we're going to enforce that with state power, we have to ask such additional questions as, will this enforcement continue to support and sustain respect for the institutions of self-government? What if we thought we would undermine that respect by creating a legal obligation? That'd be a very risky thing for us to do. Is it likely that people will obey? We learn from prohibition. Sometimes Americans just turn into ornery cusses and disobey the law, right? Folks who were trying to draft people during the Vietnam War met resistance from draft resistors. That's what they were called. And there's now a strong political movement in our country that is suspicious of all kinds of exercise of state power. That's deep, by the way, in American culture. It just so happens it's right up on the surface at this point in our history. So that one has an ethical obligation doesn't mean automatically that one has a legal obligation. And it goes the other way. That we can't show you have a legal obligation doesn't mean you don't have an ethical obligation. So frequently in the pediatric ethics literature, someone will say, well, we would never force parents to do X. Therefore, parents are not ethically obligated to do X. No. If the forcing is by the state, it means that the conditions for the use of state power aren't met. The ethical justification isn't met. It doesn't mean that the ethical justification for parental obligations that are not going to be enforced by state power aren't met. How are those obligations going to be supported and encouraged? By conscientious clinicians, which is how most of pediatric ethics gets carried out every day all around the world. So very important when you see someone say, well, we would never force someone to do X, therefore they're not obligated. That's a fallacious form of argument. Okay, everybody with me? Alrighty. Now, ethical virtues and principles. So here's some more language we need. What is a virtue? It's a trait or habit of character that disposes us to blunt our self-interest and act on our obligations so that we function well in the world. And a core virtue in healthcare ethics is professional integrity. That is, you practice, you conduct research, and you teach medicine, nursing, genetic counseling, medical social work, and the other healthcare professions to standards of intellectual and moral excellence. The study we saw described by Dr. Powell is trying to figure out what are the standards of that if we're going to introduce genome sequencing into newborn diagnosis and risk assessment, right? What are the standards of scientific excellence, of clinical excellence, and moral excellence so that when we do this, or first of all, should we do it, and if we do it, we make sure we're doing it right. What are the core ethical principles in this setting? The first is beneficence, and that's you're ethically obligated as clinicians to act in a way that's going to result in reliable clinical judgment in net clinical benefit. And as we work through the expanded scope of newborn screening, if we go to next generation sequencing, then we're going to wonder what is the benefit? Is there net clinical benefit for this newborn from that expansion? And we have to think about what are the medically reasonable alternatives, those that in deliberative clinical judgment are assessed to have net clinical benefit for patients. When that test isn't met, there's no obligation to do it. We're at the limits of beneficence-based obligations, and we're free not to do it. Next is respect for autonomy, and that's to empower decision makers in the clinical setting, that is adult patients for themselves or parents of pediatric patients, with the information they need to assess those medically reasonable alternatives and then to authorize one of them or refuse to authorize any of them, in which case we have a real ethical problem on our hand. And what is justice? Justice is the general ethical principle that says, give to each individual what is due to that person. We got to figure, okay, what's due to them? Well, in healthcare, what's due to them is integrity-based healthcare. So justice in the healthcare setting means that you implement professional integrity by seeing to it that each patient receives clinical management supported by deliberative clinical judgment. So if in deliberative clinical judgment a patient needs a very expensive diagnostic test, then we got to see to it that it happens. How do we do that in our society? We have to pay insurance premiums that will cover that cost, and we have to pay taxes into the public programs that cover that cost. And then, of course, we have to very carefully distinguish between price and cost, right? You mentioned the markup. My medical school doesn't mark up anything. That's what's known as an acute delusional state, right? Of course it does, and it marks it up by exactly the right amount. So does the University of North Carolina. It's other institutions that are culprits, not ours, right? Seriously, this is going to be a big debate in American healthcare because cost and price have got a big gap, and maybe we can close that gap and save an awful lot of money. You're talking about my salary, right? And your salaries, those of you who are in the healthcare business. This is coming. So Get yourselves ready. It's going to be interesting. And as usual, it will be a calm, polite, well-informed, and completely courteous discussion among well-meaning neighbors. There's another delusional state. Okay, so let's start putting this together. Healthcare professionals have a prima facie, integrity-based, beneficence-based, and justice-based. Notice they all converge to provide clinical management that in deliberative clinical judgment, not what you happen to think, but what you deliberate about, is reliably expected to reduce the burden of disease on patients by providing primary, secondary, and tertiary prevention. That's what healthcare is about, is reducing the burden of disease, disorders, and disabilities on patients. Next, as surrogate decision maker for their child who is a patient, parents have a parallel prima facie beneficence-based obligation to authorize clinical care that in the clinician's deliberative judgment will reduce burden of disease in their child. Right? So the authority of parents ethically is a function of the deliberative judgment of pediatric healthcare professionals. Right? Very important. That's a constraint on their freedom and their judgment. So parents have a prima facie obligation to authorize what's in their child's health-related interests. So the question is, in the area of genomics and newborn screening, what is that? Now, it goes on. Let's turn to social dimensions. All of us in society have an ethical obligation to reduce the burden of disease on our fellow citizens and non-citizens, anybody who lives in our country, and everyone who lives in our country. This is what's called promoting the public welfare. It's actually in the preamble to the United States Constitution. And they understood the burden of disease in the late 18th century. So what was the likelihood of a woman living into her 30s if she became pregnant in the 18th century in America? Very low, right? What was the likelihood that all of your children would survive into their late teenage years? Less than 50%, right? So they understood what the burden of disease was, and so when they called for the public welfare to be protected, that was one of the things they had to do. Now, doing that on a societal level is beyond my resources or yours as individuals. It's why we have institutions of government, is to carry out those society-level obligations to reduce the burden of disease, to provide for the national security. There's a whole bunch of them that require social levels. Now, it's interesting, we all also have a legitimate interest in reducing the burden of disease, because all of us at some point or other are going to get sick or suffer a disability or have some sort of disorder. None of us are free of that risk, right? Unless you have a chronic delusional state and believe to the contrary. George Will years ago had a wonderful column on this where he says, "We the not yet disabled," right? It was a very nice way to put it, to remind us all of us are in this together. So notice what happens in public policy. When there's an obligation to reduce the burden of disease and it coincides with an interest to reduce the burden of disease, you've got the strongest possible ethical argument in health policy. When interest and obligations converge, then we have to go down that road. So this sets us on the path of improving the quality of newborn screening, but with what limits? Now, what's the current focus of genetic assessment in newborn screening? Is we're preventing on the loss of life, obviously, and then serious, far-reaching, and irreversible loss of health in children. So if it's not so serious, if it's reversible, if it can be detected later, then we can postpone this, right? So it's deliberative clinical judgment is telling us these are urgent health matters that require our attention and our priority. We're focused on an autonomy-based obligation to parents. We need to give them the information they need so that they can step up and then fulfill their role in the care of these children, especially those with chronic conditions or diseases like PKU. That is a lifetime of work for the parents with that child. And as I learned in the conference in San Antonio last week, 2 young women, the parents are still working with them as they're going off to college. So this is a lifetime of commitment that exists between parents and children. They've got to have information and support to do that. And then again, we should implement the obligation to see to it that each patient receives secondary prevention, because that's what this is all about, supported by deliberative clinical judgment. Now, here we go. Should the focus of newborn screening be expanded? Here's how I understand that focus to look. First of all, we're going to get more diagnostic information. So if we add whole exome or whole genome sequencing, but more likely whole exome sequencing, I think, is the first step. We're going to be able to diagnose more conditions, disability, diseases, disorders, and syndromes in a patient population. So should we do that? Should we expand the diagnostic capability of newborn screening? Next is we're going to get risk assessment, which, by the way, clinicians have been doing for a long, long time. Since I live about 7 miles west of the largest petrochemical refining complex on the North American continent, it's one of the virtues of living in Houston, right? I'm at risk for exposure to carcinogens, right? It's not by accident that the MD Anderson Cancer Center is located in the city of Houston. There's a connection there, right? So do I have an increased risk of environmentally caused cancers? And the answer is yes, but I'm a proud Houstonian, so I don't mind, right? As you've noticed, I'm a fair-skinned person of pure Irish extraction, a heredity I do not recommend to anyone, right? But there were 11 of us in the Alamo, so the whiskey must have been very, very good, right? That's true. You walk in and turn to the right, you'll see the Irish flag. So risk assessment, right? What does that mean? You're at increased risk for disease as a child, as an adolescent, 40 years from now? What's it mean to have an increased risk of cardiovascular disease of 20% over the background population? Is that something I should worry about as a patient? This gets fuzzy and hard to think about. Next, you can learn carrier status of an infant. Is that a wise thing to be doing? Could that alter the relationship between parents and children? I'm part of a study in a similar group, the U grants from the National Human Genome Research Institute, where we're looking at introducing whole exome sequencing into the care of children with solid tumors. And we're following a cohort of parents in the Project 3, it's called, through this whole process. And a number of us have told that they think they should get that information because they want their children to become responsible reproducers. They're talking about a 4-year-old or an 8-year-old at the time. Very interesting concept, because the dominant concept in the genomic ethics literature is preserving an open future for the kid. These parents are saying, I want to preserve a responsible future for my child. Is that a good enough reason to give them carrier status results from genome sequencing in a newborn when they've got a lot of other things on their mind? And then the variants of unknown clinical significance, sometimes abbreviated VUS or VUS, my favorite acronym that I've learned recently, right? These are especially those where there are allelic changes in genes known or suspected to be associated with pathogenic pathways. So these aren't just idle curiosities. These are clinically significant theoretically, not clinically significant with evidence. A really crucial distinction to keep in mind as we go forward. Now, there is agreement on the following, and that's why the Human Genome Research Institute is funding such studies as we've heard about from Dr. Powell, is that if we're going to expand the scope of newborn screening or any other diagnostic area, let's do so carefully with some research results in pilot studies before we do it, because it could go badly. And if it goes badly, then we need to pull back and think about it very carefully. In other words, this approach is designed to prevent the enthusiastic introduction of this. Now, in the commercial sector, since so far legal institutions have said these entities that just send you your genome without any clinical information aren't practicing medicine without a license, this is going to go on. How much longer they can do that, I think, is going to be up to courts and legislatures. That we can't stop unless the state and federal governments take measures, which the FDA has recently, to try to regulate this. So here's how I sort these out in terms of primary, secondary, and tertiary prevention. First, diagnostic information is secondary prevention. That's what we're already doing in newborn screening, so it fits right in there. So the question is, should we add new diagnoses? Risk assessment, I think, is primary and secondary prevention, but mainly primary. Carrier status is surely primary prevention. You're giving information to someone that he or she can use with a reproductive partner to prevent the occurrence of the birth of a child with a disease. But the variants of unknown significance are theoretical prevention. And ordinarily, in the clinical setting, there's no obligation to engage in theoretical prevention. And the reason for that is You start interfering with people's lives on the basis of theoretical benefit, you might actually make them worse off. And that's not an acceptable outcome from the perspective of the principle of beneficence and the professional virtue of integrity. So let's keep that in mind. So here we go. Let's ask these questions. First question is, we can do diagnoses of early onset conditions and diseases that are life-threatening for which there is effective clinical management. So if we're going to bring genome sequencing into newborn screening, should we add all diagnoses that fit this category? And this one is easy because that's what we're already doing. So these already fit the accepted ethical justification for newborn screening in the first place. The only thing new is the scope, not the type of diagnosis that's going to be added. Right? So this simply says in standard ethical reasoning, if you're already doing something for good ethical reasoning, and this is the exact same kind of thing, then it fits right under it and we can go forward with confidence. Now, what about later onset conditions that are life-threatening for which there is effective clinical management? I see heads nodding yes. What's driving this? What's the primary ethical consideration that's driving the yeses in the room? It's the life-threatening. Why, from a clinical perspective, is the death of a child a very bad thing? By the way, it is from lots of other perspectives as well. But from a clinical perspective, why is it a bad thing? Because biopsychosocially, there's all that loss, right? And that's a loss, and we want to try to prevent that loss. Obviously, the death of a child is a calamity for parents, at the least, no matter what culture they come from. By the way, in the 18th century, it was a calamity, even though it was common. For us, it's much less common now in a developed society like our own. So these two seem to be fairly straightforward, right? Okay, next come three formulations focusing on serious, far-reaching, and irreversible threats to health, right? One is early onset, for which we can effectively provide some management. The next is later onset, for which there is effective clinical management. And then later onset, where we can postpone the secondary prevention until adulthood. Remember that nice slide Dr. Powell had ranging the diagnoses along a temporal continuum with that nice line at 18, I remember, age of 18, right? By the way, why is adulthood set at the age of 18, not 21 as it used to be? Because of the Vietnam War, right? People between the ages of 18 and 21 were subject to what during the Vietnam War? The draft. Could they vote for the people who were drafting them? No. So this was called drafting without representation, invoking the famous line of the original Tea Party, taxation without representation, right? So it was lowered for a political reason. Are 18-year-olds capable of acting in a mature fashion at all times? I was. And I can say that because both my parents are deceased and aren't here to refute me with overwhelming evidence. Right? My mother said, none of you became adults till you reached 35, and I'm not even sure about that criterion. Right? So let's think these through. So if you got a serious threat to a child's health, it's going to be early onset, and there's something we can do about it. Does that get the okay? And that's the appeal to the principle of beneficence. Right? Serious, far-reaching, and irreversible threats to health are right below death in the ethical principle of beneficence for priority for prevention. Right? Okay, next one. Serious, far-reaching, irreversible threats to health for which there is effective intervention during childhood, but the manifestation will come later. So that we can prevent serious threats. So it doesn't matter when the threat occurs. That makes it important. As long as it's something we can do something about in childhood, that gets on the list. Now, the third one is we can safely postpone those interventions until later when the child becomes an adult and can consent for himself or herself. Do you find yourselves not sure how to think about that one? In my mind, this is where we make the transition from straightforward to challenging. This is one, and by the way, they get harder from here on out, right? Right, this is a harder one, right? Because it can wait. Now, clinicians in the room know what's the peril of saying it can wait. It can get worse and it can never get done, right? I'm sorry? We think it's adult onset. What if there are subtle pathological changes occurring before that that we don't know about because we're ignorant? By the way, not at my medical school. Everybody's smart as a whip, right? Not in this room, remember, elsewhere. Very good point. So what if our current understanding that it is altogether late onset turns out not to be true? And with iatrogenically low burden prevention, we might have had a greater effect. So our caution about our own ignorance makes it a little higher in priority, but it's going to be a function of the iatrogenic burden of that prevention, right? And the disruption it causes in someone's life. So maybe this one goes on the list. Maybe this is one we want to keep thinking about before we put it on the list, but it's a good candidate. Is that a fair summary? Hmm? Right, and that's the prudential voice of caution speaking, right? So if you combine prudence with the principle of beneficence, you get the position you've just taken, right? And it's okay to be prudent, even though Dana Carvey made a lot of fun of the first President Bush saying that. But prudence is a good old virtue that says, identify your legitimate interests and act to protect them. Our health is among our legitimate interests, so we ought to act to protect it. If we're uncertain about when these adult onset processes really begin, right, then the priority moves up, right? Okay, good. So this one seems to have considerable priority in deliberative reflection, right? Alrighty. Now we're going to talk about risk assessment, okay? And it's the same sequence. It's risk assessment of early onset conditions where we can do something to reduce that risk assessment of later onset conditions where we can reduce the risk by intervening during childhood, or risk assessment for increased risk where we can wait and postpone the intervention. Right? So this is information we could get, we're going to get a lot of you get a lot of risk assessment from genomic analysis. By the way, you get a lot from that if you have a good family history. And what we already know about the heritability of conditions, you get good risk assessment, right? So you ask your patients' clinicians, right, tell me about other people in your family. And if they see a pattern of disease there, that's going to give them information about your risk. Now, genomic information will make that judgment more precise, I think is the way to put it. But it's not as if it will make it clinicians have been making risk assessment judgments for a long, long time. We just are now going to have much more scientific precision for them. So let's look at the first one. Risk assessment for early onset diseases where we can modify the risk safely during childhood. Now it's gotten hard, right? What's making it hard? Is how to assess risk, increased risk in the principle of beneficence. Is it by the magnitude of the increase or the nature of the disease for which there is an increased risk? Knowing that as healthcare sciences and clinical practice make progress, maybe we can have better treatment of those conditions later. Maybe. We can agree on this. This is not the same as a life-threatening condition for which there's immediately available effective treatment in childhood. So it's not like that at all. It's something more remote from that, and it's more remote in its immediacy. It's more remote that it's not life-threatening, and it's more remote that it's not a serious and irreversible threat to health. It's an increased risk to health. It could be irreversible, right? Now put on your George Engel hat and ask yourself, do you want to introduce the psychosocial complications of this information into the lives of parents and children? Pediatric healthcare professionals in the room, does that sound like a wise thing to do? Who said not always? Good, very good answer. So this gives us pause, right? What if the family's in fragile social circumstances and has enough on its psychosocial agenda? Mom and dad, for example, both just lost their jobs. Let's ask it this way: do they have an obligation to learn this information as parents? Okay, but if there's an obligation for them to learn, then it has to go on to the list, right? If they have a right to it, that right's going to be constrained by this question: is it in the health-related interest of the child to give parents this information? Not always, says your pediatrician colleague here. I know that because I was sitting next to her at lunch, right? Not so clear, right? Should we hesitate at this point? Standard rule in ethical reasoning: as your ethical reasoning becomes, as you struggle to make it more deliberative, you should hesitate to draw any strong conclusions, right? That's, as it were, a cautionary principle in ethical reasoning. Why? Because that's the antidote to ethical enthusiasm. Of course we ought to share this information. I'm sorry? You have an ethical obligation to disclose medically reasonable information. That is, where there's an expectation of net clinical benefit to the child of giving the parents the information. Is there an expectation of net clinical benefit telling parents about modifiable risk? Maybe. It's going to depend on a whole bunch of things. But a newborn screening is going to be for a whole population. So this may be something that pediatricians would be might consider offering. It's not so clear that it belongs in a population-wide genomic assessment. Not so clear. And as you go down through that list, it gets less and less clear. And as things become unclear and we're thinking about a whole population of patients, and remember the resources and cost, all that comes together to say we should really stop and really carefully think about this. Here's a really short slide: carrier status. 2 words, when assembled together, should cause us to become very deliberative in our thinking. Is it in the vital health-related interest of an infant for his or her parents to know his or her carrier status? Can we make a case that this is clearly in the interest of the child, health-related wise? Of the infant, right there and then? And the answer is nope. Can we make a case for it before that child reaches reproductive capacity? Nope, which will occur the first week after birth, the way things are going in our species at the moment. But if you really want to frighten a parent, don't say that. Say that your child is destined to grow up, go to college, and study art history. That was my major, right? Causing my father to say the night before graduation, "And now what are you going to do?" Right? Tell them they're going to go off and become an electrical engineer and write computer code and invent a game with friends that's worth $1 jillion. They'll smile and be happy, right? Of course, 30 years from now, we have no idea what the world's going to look like for that kid. So carrier status, is that clearly in a child's interest that the parents know that? Is it clearly in their interest that that they know it? What if they're curious to know it? Should we base public policy on random curiosity distributed among the population of parents? As soon as you formulate the question, the answer is no, right? Very important point. Curiosity does not create an ethical obligation to disclose medical information. Clinical significance creates an obligation to disclose medical information, not the curiosity of parents. We live in a society where we think curiosity creates a constitutional right to know something. And I'm going to get it enforced by a court of law. I'm serious. That I think is in the popular culture. And so this is going to be standing athwart of the popular culture. So it's not at all clear that carrier status. And finally, variants of unknown significance, whose value at the current time is only theoretical, or as clinicians put it, purely academic. right? When you hear that phrase, purely academic, you know it has no clinical significance, right? Or even better, of philosophical interest. I love that one. That's me, right? Right? Does this make it? Does this make it onto a research agenda? No doubt about that. It doesn't make it onto a clinical agenda, especially a population-wide program, right? So this does not get on there. Now here's the problem. If you use genomic sequencing, you're going to get all of this stuff, because that's what the technology gives you. Now, if I understand it correctly, Dr. Powell, the way to prevent that is stop at microarrays, because that's still targeted genomic testing, right? Although you're going to get some variants of unknown significance even on that one, but it's in targeted alleles that genes you're actually looking at. This is different. And the analogy is if you took a whole body scan of a patient in a radiology department, you're going to get an image of the entire body. The radiologist is going to look at the whole thing, right? That's like a radiological sequencing of the entire human body. They're going to look at everything. If you don't want them looking at everything, don't order a whole body scan, right? So that I think is the problem here, is that the technology creates categories of information for which we don't have an ethical justification for returning that to the parents in a population-wide program. So to recap, so the diagnostic information, that looks like fairly straightforward, right? That goes on there, especially diagnoses of life-threatening conditions that we can do something about, and also of serious threats to health. We may also want to put on there diagnoses for which there's no effective treatment, out of respect for the desire of many parents to know that. That's something to think more about. I'm not going to suggest we should conclude that at all. Then risk assessment. I think there was, as we especially went down through that list, it wasn't at all clear we should do that. Carrier status, probably not, and the variants of unknown significance, definitely not, because they're only theoretically significant. Remember, in beneficence-based clinical judgment, you do not act on theoretical significance. The example that I like to use is in obstetric ultrasound. It is known to cause cavitation, that is a swirling effect. It also increases the temperature of amniotic fluid. Those are theoretical risks. There is no documented risk to that. So an obstetrician offering a woman a first trimester skeletal survey does not have to tell her that there are risks of cavitation and increased temperature. By the way, cavitation is how we find Russian submarines, because the propeller causes cavitation in the water. The propellers on American submarines do not. And how do we know that? Because they're American submarines. What's wrong with you people? So we have gone through an exercise of forming deliberative ethical judgment about the impact of this new technology on population-wide genetic assessment, and have reached the judgment that if we're going to go this way, there's going to be domains of information that will not be obligatory to disclose. There are domains of information that will be obligatory to disclose, and in betwixt those, that risk assessment group will be domains of information that we're not sure which category it's in, obligatory to disclose or not obligatory to disclose. Another very good reason to do pilot studies where you randomize giving back, just as your study is doing, that information, and to see what happens when you do. Because there might be some populations of parents for whom you make things better, and other populations of parents for whom you make things a whole lot worse. And maybe we could characterize those ahead of time and try to assess the risk of going to a population-based use of this technology. So this is a really good example of how the increasing scope of a technology creates an ethical challenge for us, because it goes beyond the traditional scope of newborn screening. So it's the technological power of this technology that creates the ethical challenges for us, because the current ethical framework that's very stable and that has guided newborn screening for decades now isn't going to be adequate, especially to risk assessment, carrier status, and the variants of unknown significance. Here are my references I've relied on, and I'll be glad to see if you all have any questions. I'm sorry, yes. Can you wait for the microphone?
Who decides what type of disease factors or risk, assessment you can disclose and which you don't have to?
Well, this will be a matter of health policy. So this will be, in our case, the Texas State Department of Health Services. Thank you, state. I always get it. I have dyslexia of state agency names. And our legislature, informed by especially the professional communities.
So the physician is not liable for disclosing or not disclosing.
If the policy of newborn screening covers the information that the state agency will send back to you as a clinician, that leaves unanswered the question of what do you owe to that particular patient with the additional information you might get from a genome analysis, if we go that way.
Okay.
And then the question would be, for that patient, is it medically reasonable information? That is, should you have had a deliberative judgment that there would be net clinical benefit from providing that information? Now, we saw for variants of unknown significance, the answer clearly is no such expectation. Carrier status didn't seem to, and the risk assessment, we struggled to figure that out. So someone who would say, well, of course you have to give all that risk assessment back, had better produce one heck of a good argument to dispel our uncertainty. That's how you'd think it through.
And somebody has to have an agency supporting the policies of what need to be disclosed.
Right, and then the professional associations of, say, of the Academy of Pediatrics, if it were wise, would try to come out with a statement, with, say, maybe some guidelines for how pediatricians should reach these judgments. That would give you some backup for your judgments.
Okay.
But the test is always going to be, if the information has clinical significance, then of course you share it.
Sure.
If we're not sure it doesn't, it's not at all clear there's a duty to share it.
That's what I'm talking about. The carrier state or the academic interest. So what is my liability on that?
Right. So it's interesting, the genome sequencing information goes from clearly medically reasonable to disclose to clearly not medical reasonable to disclose, with the risk assessment right there in the middle area. That's the hardest group to think about.
Okay, thank you.
Thank you.
Oh, in the back there, yeah.
Is that not giving the doctors too much power to decide, is this family going to be able to handle this or not handle this additional information? And it just seems wrong for a physician to know something, that a risk down the line, whether it, if there's no significance at that time. But just for you to have information about my child or someone's child that you get to hold on to, but I don't get to know that because you think I can't handle it.
No, that's a really good question, and that's not the judgment. The judgment is that if it's not clinically significant, then there's no obligation to provide it to you. And the worry is, if we did provide it to parents who then who might not grasp clearly that it's not clinically significant, you might introduce factors into the relationship between those parents and their child that could turn out to be very deleterious over the long run, that were not clinically justified to risk. So there's an unknown risk of injury to the relationship between parent and child of sharing information that's not clinically significant. Now, if the judgment is that parents can't handle clinically significant information, the burden of proof for that judgment is very, very steep. And usually when clinicians say the decision maker can't handle it, what they're saying is, I'm very uncomfortable having to share this information. Well, that's not a good reason not to do it. So you got to be careful of that one. And by the way, that's not me. That was John Gregory in the 18th century said that. I take my instruction from him. Now, do pediatricians believe, many of them, that they should shoulder some of the burden of decision making from parents to ease that burden on them? And I think the answer among many pediatricians is yes. Whether that's a good thing or not, I think I'm not sure what to think about that. But a judgment that a parent's not ready to hear it or can't deal with it, that's not what the judgment we were making was a beneficence-based judgment about clinical significance. That's the distinction we were trying to make, so that you don't introduce noise into the deliberative reflections of parents, because that's risk disabling their thought processes, quite unintentionally, by the way. It's a very good question. Does that address the concern?
Yes, I hear you.
Yeah.
Okay, well, thank you, Dr. McCullough,
Welcome.
and a memento of your visit here.
Thank you.
Thank you.